Thanks, Mr. Chairman. بسم الله الرحمن الرحيم. احنا هنتكلم simply what we need to know about achieving a successful meniscal repair. We all know that meniscus has essential biomechanical role in the joint, load bearing, distribution, transmission, also instability, joint congruence, articular cartilage lubrication and nutrition, and also proprioception. Why do we repair the meniscus? Because the meniscus evenly distributes the axial stress to the whole tibial surface by mechanism of hoop stress. We need intact meniscal roots and intact peripheral circumferential fibers to achieve this mechanism. We know that there is a risk of any knee reoperation after meniscal repair compared to meniscectomy about 4 folds, and same meniscus reoperation about 17 folds compared to meniscectomy. But we also know that there is about 25 to 50% lower risk of consultation for osteoarthritis in case of meniscal repair as compared to partial meniscectomy. That's why we try to repair the meniscus whenever possible. This is what occurs when we do meniscectomy: decreased contact area, increased peak contact forces, and we end up with osteoarthritis. The anatomical classification that we all know: anterior and posterior roots, anterior horn, middle part, posterior horn. As regards the vascular classification for repair, the peripheral good vascularity zone, the red zone, intermediate red-white, and the inner white zone with the lowest vascularity. Tear patterns that we know: vertical tears can be peripheral longitudinal, bucket handle, flap tear, or a ramp lesion when it occurs at the meniscocapsular junction. When the tears occur perpendicular to the circumferential fibers, can be radial tears or root tears with possible meniscal extrusion. The horizontal tears divide the meniscus into upper and lower leaflets, usually does not decrease the contact area. It can be associated with parameniscal cyst, and the pain is usually from irritation to the peripheral synovial tissue. Combination of vertical and radial tears can cause complex tears. Combination of vertical and horizontal tears can result on oblique or barrowed peak tear. Which factors to consider when we do meniscal repair? Factors related to the tear pattern and factors related to the age of the tear and the age of the patient. In vertical tears, especially when they are in the peripheral red zone, has very good healing potential, 72 to 94%, and that's why they usually heal quite well. Even peripheral longitudinal tears of less than 10 millimeters in length, even if left untreated, they have very good healing potential. Radial tears, also if they extend into the peripheral red zone, have a good healing potential but need special suture configuration. We will discuss this in the technique. And for horizontal tears, احنا قلنا ان هي مش بتقلل contact area, but we need to know that removing one leaflet increase the contact pressure up to 60% and is equal to removal of the 2 leaflets. That's why when we evacuate the cyst, refresh the edges, we should try to repair even the horizontal tear whenever possible. Age of the patient, age of the tear is not a significant factor. The interval between trauma and surgery is not a cause of failure. Age of the patient is not a cause of failure of meniscal repair. Useful tricks in meniscal repair surgery: we all need to know if we plan a meniscal repair. MCL by crusting in cases of tight medial compartment in order to avoid jamming of instruments, injury of the cartilage, poor visualization. The MCL by crusting widens the medial compartment and facilitates surgery. Also, refreshment of the edges is very important. We need to have some group of rasps or instruments to refresh the tear and enhance the chance of healing. Techniques اللي احنا بنستخدمها اللي معظمنا عارفها: all inside. We repair the meniscal tear from all inside the knee without additional incisions. We place anchor devices with self-tying slip knot in order to repair the meniscal tear. This is the all inside repair. After implanting one or 2 devices, the self-tying slip knot is tightened to repair the tear. Outside in, we pass the suture material across the meniscal tissue from outside the knee to the inside, leaving the loop across meniscal tissue, and then the suture is tied outside the capsule from the periphery through a separate incision. Different techniques to retrieve sutures from inside the knee may be a wire snare, retrieving the single loop, leaving tissue across the meniscus, suture material across the meniscal tissue, or very simply using two needles, passing a single limb and a loop limb, then retrieving the single limb through the loop, creating the vertical or horizontal sutures. All inside out meniscal repair, passing the sutures from inside to outside the knee, then tying the sutures on the periphery of the capsule through a separate incision, can be done with various sets of needles with pre-attached sutures or with needles with eyelets, sometimes helped with curved delivery systems to access the difficult areas of the meniscus. So as a rule, we all use the all-inside devices for the posterior horn to avoid injury of the neurovascular structures. We keep the outside in for the difficult access anterior horn of the menisci. Middle part, we can do both outside in, inside out, or sometimes even the all inside. Sometimes we use the hybrid if we have a long peripheral longitudinal tear, to avoid using the very expensive all-inside devices every 4 to 5 millimeters across the tear. We use outside in combination with all inside to end up in a construct like this one, including outside in for the middle part and all inside for the posterior part. Which suture configuration for each tear? For vertical longitudinal tears, vertical matrix sutures has a higher biomechanical advantage over the horizontal. For the radial tears, we sometimes use the grip tie or hashtag stitch. We place vertical sutures first across the meniscal tissue before placing the horizontal ones, to avoid that the horizontal suture material cut through the circumferential fibers. That's why it's called the grip tie or hashtag stitch. For the horizontal tears, after evacuation of the cyst, refreshing the edges, we might use the high belt technique when we encircle the two leaflets with multiple vertical sutures, whatever the technique is, to avoid recurrence of pain and recurrence of formation of the cyst. Ramp lesions, meniscocapsular separations, they require creation of posteromedial portal and then passing tissues, passing suture material across the capsule and also across the meniscal tissue, and then tying to repair the ramp lesion. Simply passing sutures across the capsule, across the back of the meniscus, and then tying the knot to repair the ramp lesion. For the root tears, we need to create some tibial tunnel. مش شغال لا حتى الماوس مش We refresh the site of attachment of the meniscal root. We pass a drill guide at the site of the planned tunnel. We create a tibial tunnel, and then we pass suture material across the meniscal root, pull them out on a cortical suspension device over the tibia, and sometimes for correcting the meniscal extrusion, after adding the main stitch, we add a centralization stitch, also passing through a tibial tunnel in order to reduce the meniscal extrusion. What about the use of biologics? Bone marrow venting procedures. When we do a meniscal repair and combined with ACL reconstruction, some marrow material gets into the knee from the bony tunnels, enhance the healing. If we do isolated meniscal repair, we sometimes do a microfracture in the notch to invite some bone marrow and enhance healing. Mechanical stimulation, as we rasp the edges, create some improved vascularity and enhance healing. Trephination also improved vascularity and healing. Fibrin clot, studies about it, but it's very difficult to apply. Bone marrow aspirate, very promising results with enhanced healing potential. Platelet-rich plasma is still controversial and need more studies. So in conclusion, Meniscal repair is an important surgical skill with high level of evidence of effectiveness. Most meniscal tears have to undergo at least an attempt of repair. All inside fixation devices are particularly used for posterior third tears, decreasing the risk of neurovascular injury. They can also be used in the middle third tears. Outside in, زي ما قلنا for anterior third tears, difficult to reach. Both inside out and outside in can be used for the meniscal body or the middle third. Ramp lesion needs to have the skill of creating a posteromedial portal, and root avulsions need creation of tibial bony tunnels, and biologics might improve the chance of healing. Thank you.